Hi guys, and welcome to part 3 of circulatory system. We want to talk a little bit more about the vessels. So I had mentioned the naming of them. We call arteries are vessels that are leaving the heart, and a large artery is an artery, and as smaller as it goes branching and that radius gets narrower, we call it an arteriole. So the arteriole is the name that we give for a smaller, narrower artery. And keep in mind that all this distance here is just transport. There's no oxygen being delivered to the tissues in this area. The only region that is delivering oxygen to the cells is in the capillary bed. These vessels are tiny. They are smaller than the diameter of a hair. They only allow about one cell, I'm going to draw a little red blood cell there, going by one at a time. So they are very, very tiny. And it also slows down the velocity of blood. Slows down considerably, allowing that exit of oxygen here in that region. And it's not happening in the arteries, it's not happening in the arterioles, it's happening only here in the capillary beds. As this becomes more deoxygenated, it's going to look more purple, it's going to end up looking more blue, and the venule region here then is a little vein coming up, joining with other little veins to form larger veins that will then eventually come into the superior vena cava. And another vein that I didn't mention to you is one that's bringing blood from the lower body, and that's going to be the inferior vena cava or vena cava. You can say it either way. So that is just a small review of what these capillaries, what these vessels look like. If you wanted to take a cross-section of them and look inside, and we're going to start by doing that with an artery, what is in the wall of the artery? So what you would see is an inner lining, which is an endo. Endo means inside. An endothelium, meaning liner. So an inner liner, followed by a second layer of a tissue that we call connective tissue, which is just specialized for just also as a wrapper. It's not an immediate cover, but it's sort of an in-between tissue, hence the connective. Then there's a big layer of smooth muscle. I change the color of my pen here. And this in an artery is quite thick. Look at that muscle there. Because it can contract. And the last one is another connective tissue on the outside. So these are sort of in between tissues that cover. So important that the artery has quite a bit of muscle. It is able to hold its shape very well. And it can contract. And it can relax. So if it contracts, it narrows this radius here. And if it narrows the radius, it's kind of like taking a hose and making it somewhat narrow. You increase the pressure and decrease the flow that goes through that particular artery. Let's talk about what some things that could go wrong. We do have that musculature layer, but if there is a weakness, let's say there's a point of weakness here along the sides of this aorta, for whatever reason. Sometimes it is the result of a viral infection. So major artery leaving the heart or is the aorta, and it will come around like this and then come down to the abdomen, in which case we call it the abdominal aorta, and there it will branch blood out. Well, here, this one has ballooned out under pressure, under the pressure of the blood. And this is not a good thing. This is an aneurysm that could potentially burst and have blood flowing out, and this is fatal. So this abdominal aneurysm is absolutely dangerous. So that's a little bit about arteries. What about capillaries? Capillaries are very, very narrow. They're 100 times narrower than a strand of hair. And this is showing how a red blood cell, only really one fits at a time as it travels down the capillary. The layer here in this capillary, it does not have muscle. It just has one single cell endothelium here because you want oxygen to be able to cross that membrane easily. And if you had 20 layers of muscle cells, that would be quite impossible. You want to be able to pick up waste also. So very thin, one cell thick layer within the capillary. What about the walls of the vein? Well, they have that inner lining, endothelium. They have a connective tissue which wraps around it, that in-between tissue, and then they have smooth muscle. But look at the size of this. It is very thin, much, much thinner than that layer that you saw in an artery. So if you had an artery and a vein side by side within the body, and touched them, you would find one that's very rubbery and elastic, and the other one that if you touched it, it would flop, sort of flops on itself like a wet balloon. And that would be the vein because it does not have a thick layer of muscle. And this is again a liner of connective tissue on the outside. So that is what you would see in the walls of veins. Again, venule is a small vein. Notice inside you have these little pockets here. And why do you need that? Well, it's difficult to get blood pumping, let's say from the bottom of your toes up to the top of the heart again to pump to the lung if you don't have a whole lot of musculature here, if you don't have a lot of muscle wall to be able to squeeze that. And so there is danger of this blood just dropping back down again and with gravity and just pooling in your feet. So that's not a good thing in your ankles. So by having valves inside the walls of a vein, it doesn't let some of the blood from above go beyond the valve. It can't, if it were between, some would fall, but most of it gets caught in these valves, so that the outcome is that you move blood up back towards the heart and not have it dribble back down again. This is a better picture of those valves. This is an illustration of the leg. You would have a muscle, another muscle, and in the middle you would have the vein with these valves. So when this blood tries to go back down to the feet again, you would have the closing of this valve, and the next time that you were to contract your leg here, it would squeeze. Do you notice how this has created a squeeze here through the mere contraction of your muscle legs that were doing something else, just moving or walking or running, and it would actually squeeze that blood up beyond the next set of valves, and in that way keep moving it up back towards the heart. Sometimes these don't work well. When they don't work well, it could cause these nasty varicose veins. So the blood ends up pooling. Do you notice? It's pooling in these veins here. And it's unsightly also. So mostly this happens in superficial veins, and the blood doesn't quite, it eventually makes it up to the heart, but it's slow to do so and it pools along. This could be painful. So they do surgery on this if it becomes very painful. What they do is that they'll cut this vein out. So they could do something like this and just remove it. And by removing it, the veins that are in the vicinity here are the ones that are going to pick up blood from that area. There's no guarantee that those two won't become varicose, but not always. So here again, maybe this vein here would be removed in hopes that the other veins in this region would take care of that blood. Another type of varicose vein is a hemorrhoid, and that's a varicose vein of the anal canal. So if this were the anus here, you could have some of these bulging veins that could form either an internal hemorrhoid, or if they protrude beyond the anus, it would be an external hemorrhoid. Not nice either. Surgery is done on these. They can actually, cut this out and remove these if they're causing pain or a problem. If not, usually they're just left alone. What else can go wrong here in vessels? So we're going to look a little bit at atherosclerosis that could occur in arteries. So this is an artery, and this artery should continue on to have an opening that is this wide. Instead, you have in this region here, you have these lipid deposits. So we call it plaque because it has cholesterol, other lipids, calcium sometimes. And as you can see in this diagram down below, you also have, this thickness has been compromised. And just imagine then a vessel that used to be, used to have a diameter that went from here to here, now has a diameter that's way more narrow. And this causes an increase in blood pressure, right? You've made the hose narrower, and that pressure is going to shoot up. So high blood pressure could be a symptom that's coming from clogged arteries, from atherosclerosis. Notice that the endothelium is still intact here. So this deposit is essentially under this little skin. It's not a skin, it's called the endothelium. So it's underneath that the deposit occurs, making it harder to clean out. If you were to look at the stages of that formation of plaque over time, this would be a diagram of an individual with a normal arterial wall. So you would have those endothelial cells. Next in that layer would be some elastic tissue, which is able to expand and retract back. And then you would have, in pink here, the muscle cells, and then another connective tissue. And this is what it should look like. So think of this diagram as normal, and that's what you're striving for. And now this could be happening. So notice all this yellow region has now been invaded by cholesterol. So it's accumulated, and notice that it accumulates between the endothelium and the connective tissue. So this endothelium is still intact. Do you notice? But under it, the yellow deposit here has been accumulating. Now, your body doesn't want that. So it sees it as a foreign invader. So these specialized cells, macrophages, they will come up to that. They're white blood cells that we talked about. They will come up to that region and start eating up some of this cholesterol here. And so then they end up with that cholesterol inside themselves, inside the own cell. And they swell up with this cholesterol. And so then we call them foam cells because they've been eating this foamy lipid cholesterol, and we call them foam cells. So you could see plenty of these foam cells that are visible among the cholesterol. Not only that, but look at this disruption of muscle cells. The smooth muscle cell, this cell that should be down here minding its own business, instead has migrated. It's attracted by these macrophages, and it also migrates and begins to divide. It makes more of these cells and take up that cholesterol also. So now we have foam cells there, and we have these muscle cells that are also englobing, eating some of that cholesterol. Then what? So we continue with muscle cells, foam cells, and the next thing that could be happening is calcification. So if we end up with also calcium deposits that end up in this region, it's going to take up calcium. And now if you touch this, if you physically could go and touch this artery, you would feel it very, instead of very soft because of this cholesterol, it would feel sandy and gritty. And that grittiness is because there's calcium in that, making it hard. Hence the hardening of the arteries that you hear about. This sounds horrible, but in a way, sometimes the fact that it's hardened is not a bad thing, because it is less likely to rupture because of the calcium and the hardness. So we call it a stable fibrous plaque because it's not going anywhere. And that calcium is helping that stability. However, it could be vulnerable, in which case this bursts. And if it bursts, then now you have a little bit of bleeding there. You have platelets. Remember what they do? The platelets are going to clump. If they are exposed to tissue that's been damaged, then they themselves will get sticky and clump. And now you have a little clot happening and cholesterol that's flowing out of here, out of the vessel. And this is dangerous as it's transporting blood. Within the blood now, you have this big potential to clot, and you have cholesterol moving around. This is not good. And this is what could, in the brain, if it gets to the brain, the blood that's traveling along here that now has plaque in it, arrives at the brain and brings a clot with it. You could clot a small artery and the individual would have a stroke. Or this could travel towards the heart and clot one of the arteries feeding the heart itself, and the individual would have a heart attack. I made a slide so that you would have it as notes. What is plaque? It's both fat, cholesterol, calcium, fibrin, waste, and it begins to accumulate either in childhood or teenage years, which is a little frightening that it does it so early. The fatty plaque is 25% less stable than when it is calcified. You probably have heard of statins, and what they do is reduce the fat content of those plaques, making them more stable and less likely to rupture. The problem is any kind of inflammation for another reason in the body, or an infection that happens in this patient for whatever other reason, or a virus could weaken that plaque and make it vulnerable. This diagram always is a little frightening because it shows a normal vessel around the first decade of life, which is ages 1 through 10. And then this is sort of third decade, it jumps to third, where you start to have a little more accumulation. And this is a progression that could occur in a patient. And then again, some people are genetically more protected. This is fourth decade, where you have a lesion here happening. This is a lot of accumulation, and in this case here, it is called a complicated lesion because it has actually ruptured. So I guess the scariest part for me is that at age 10, you could already start having the beginnings of some deposit in your arteries. So no more bacon cheeseburgers, you guys. And that's where we're going to stop this lecture. Thank you for listening.